Jaman, Professor Kamar Jaman, Professor Akaid. Okay, let us start. Because we are running short, we could not maintain the program because the surgery session was so excellent. The radiological imaging session was so excellent. People forgot their hungriness. Okay, even then we have to do it. And another important surgery is waiting on doctor. She has got papillary carcinoma with neck node metastasis. So we'll have to do it because this lady is waiting for the long time, and he communicated with Professor Pai and Professor Koviruddin sir. They have requested her. So we should discuss on this, then we'll go to the thyroid surgery. That will be more good for this. Okay, let's come to this. This lady, you see, is a very recent picture. This lady came to me. This lady is 25 years old, presented with a solitary thyroid nodule in lymph of the thyroid. Form consistency, ultrasonograph showed solid nodule about 1.9 centimeter in diameter in left lobe, right lobe, and isthmus normal, no cervical lymph node, efficacy from the thyroid covered button. This was the picture. This lady came to this hospital, but unfortunately she could not get admitted here because you see 600 people every day coming, only we can admit only 5, 10, 20 people, not more than that. She went outside and she got operated. You see, just mark, the efficacy was negative. She got hemithyroidectomy. After hemithyroidectomy, the report was papillary carcinoma of thyroid. Nodule size was 1.6 into 1 by 1.6 centimeter. Lymphovascular invasion not present, extrathyroidal extension not present, post-operative fiber optic laryngoscopy, left vocal cord pulsing. Okay, this is the scenario. Very simple. Now, the question of this lady, sir, what should I do? Because different surgeons are talking with different. Somebody is talking, you should operate the next lobe. Another people are taking, you should wait. You should have follow-up. Sir, what should I do? So I'll request to my panelist, Kabir sir. What should you do? I am on the yeah,
size is less than 2 centimeter, no, no extrathyroidal extension, no nodal involvement. So I would recommend hemithyroidectomy and hemithyroidectomy done.
that is we should observe. That's why.
Yes.
Okay, sir. Sir, I have got it. I have got it. Sattar, have you got any other opinion? If it's same opinion or other?
Keep this patient follow.
Okay, madam.
Yes, I agree with them.
Azad.
To observe the patient.
This is low risk papillary thyroid carcinoma, lady patient. So tumor is small tumor and no external action, no neck node. Already vocal cord pulsing. I will observe. Just simple.
Bye. Okay, to the next slide. So you see, risk stratification says a size is more than 4 centimeter is a malignancy. Emergency of age, extreme ages, less than 15 years or more than 45 years, male, a recent onset, rapid growth. So she is in low risk stratification. Okay? She is in low risk group. As she is in low risk group, we can wait and we can have follow-up. So you see, this is also Tata guideline. One point is important. They have told clinical N0 or less than 5 pathological N1 micrometastasis, that is equal or less than 0.2 centimeter in largest diameter. If it is central compartment, you have got 5 lymph nodes less than 0.2 centimeter, then even you can got it in the low risk stratification and you can go for heavy thyroidectomy and follow-up. Okay. So this accidentally it was done because it was done for benign case. After surgery, it was quite incidental finding, that is the papillary carcinoma. Now the opinion of the board is we can wait. Okay. Previous slide is up. Previous slide is up. Okay. There is another. Can you do completion thyroidectomy? Is there any opinion regarding this? Because other doctor, he has told you should do this completion thyroidectomy. If we do completion thyroidectomy, should we give radioactive iodine? Madam, because one group is doing, because you know, in our country, madam, I am telling, there is a tradition, our senior teachers and even our people, they are also doing total thyroidectomy in these type of cases, because patients say, oh, you have got, one doctor has said you have got some disease with it. Doctor has not done complete surgery because for money he will do next time the total surgery. So this is really troublesome. So there is a question of completion thyroidectomy. If we do completion thyroidectomy, should we give the radioactive ablation?
Actually, as you have shown in the American Thyroid Association guidelines, this is a low-risk group of patient, so there is no need to give the radioactive therapy. And as you are saying that there is no need for completion of surgery, and this comes in 2015 recommendations. So, if anybody does the completion thyroidectomy, there is actually no need to give.
Okay, thank you, madam. What is the message? Message, you can do hemithyroidectomy in low stratification, low risk group, and not every patient should get radioactive iodine. Okay, Prathash Bhai?
So the question of completion doesn't arise. As madam said rightly, you're not going to give radioiodine to this patient. If you're not going to give radioiodine, why are you doing a completion thyroidectomy? The very idea of doing a complete thyroid removal is that now patient is suitable for radioiodine therapy. So if we are not planning radioiodine therapy in future, this patient doesn't require any removal of the thyroid gland. So it is a rhetoric question. When you are asking completion thyroidectomy, doesn't have any meaning in this patient.
No, not this question. If
Yeah,
I'm
okay,
telling
this
you,
patient.
because this is a tradition in some people, they are doing, they are advising. I'm
See,
telling
if
that.
you do total thyroidectomy, it is not wrong. But in a low volume surgeon, a person who's doing less thyroid surgeries in a year, he has a high risk of damaging the nerves,
Yes.
as we saw on one
Yes.
side.
Yes.
He doubles the risk when he does on the other side.
Yeah.
If
So
he damages parathyroid, he doubles the risk of damaging on the other side. So this patient being low risk, for what is risk? The risk is of dying of cancer. This patient is low risk because she has a 1% risk of dying of cancer. So that is extremely low risk. She doesn't require a total thyroidectomy. Even if you do total thyroidectomy, don't give radioiodine.
Oh, so she doesn't need another. She has got one recurrent nerve is already by this time paralyzed. So if you want to go there, the risk will be double. That will be disaster for this patient. So if it will be in high risk, if I had to do, then what I should? I should be very careful. I should be expert surgeon. Then I'll have to do. So next, you see, this is the 25 years, 52,000 patients were analyzed and they saw the total thyroidectomy. It is USA. Total thyroidectomy was more than the hemithyroidectomy, but the survival was almost same. So total thyroidectomy and hemithyroidectomy in case of low stratification, that is the T1, T2, papillary carcinoma and follicular carcinoma, papillary carcinoma, the modality of treatment, either total thyroidectomy or hemithyroidectomy, the survival was safe. So most logically, you people, the youngsters, the message is that hemithyroidectomy is one of the good modalities in these cases, so you should think it. Not always total. Even you see in the central compartment the lymph nodes, small lymph nodes, don't go for total thyroidectomy. And all patients do not need. Next. So this, yeah, please.
So having said that, we know that about 10 to 20% of patients will require completion thyroidectomy. Maybe because the nodule size is larger than what you saw. Two, it might have an extra thyroid spread involving the sternothyroid and the esophagus, or posteriorly placed. Or you might find a high risk histology. Is it if it's a tall cell variant, poorly differentiated thyroid cancer, you will want to do a completion. If you find a node in the central compartment and you have removed it and it is positive, it is large node, you will want to do a completion. So these are some of the indications why you would want to complete that. And in those patients, you are doing completion because this patient now requires surveillance with thioglobulin and may require radioiodine.
I'm coming, Professor Pai. You see, the what question? This stratification, which stratification is more important? This size, histopathological, and family history, age, sex, or all. Usually you will not get all the criteria together. So you will get one or two. You will get it, okay? You will get this male sex, you will get the age. These two are main common, and here histopathology you will get the common papillary carcinoma, not abnormal like this. So these are the things.
Sir, one thing, the age regarding this new ATA guideline, it will be more than 55 years.
Yeah, it is Tata guideline, so it is now 55. Now it is 55. I have taken it from Tata, so it is 55 now. No problem. So which one is more important? This size or this sex? Because some people are telling if it is male, more risky. Okay? So if she is female, if it is male, should I give this importance to this or this or this? Which one?
Sir, probably,
or all?
Probably this list will be very much.
Say loudly.
This list will be very much fit for to be malignant in a benign looking or single nodule. After surgery, we have to compile histopathological findings like tall cell, columnar cell, opnal cell.
Okay, I got it. You see, sir, please, I'm telling you, sir, I'll give you a chance. You see, sir, histopathology, they told 1.6 by 1.4 centimeter. Nodule. That was the ultrasonography imaging, and this is the histopathology. Which one I should give guide for the next step? That is the for completion, thyroidectomy and other. This part or the imaging? Which one? So, we should be very clear. Not the imaging, not the clear. The size of the nodulity of the histopathology. If we decide for the next step, the histopathological size of the lymph node. Hassan bhai, please. Yes, sir.
If you take single point in consideration, age is the most important. Because a young man, even he is metastasized, he has neck nodes, he is not in stage 4. But an older person, say more than 45, either male or female, there is a big issue. Thank you.
So he is talking about that the age, not the size. Dr. Spine.
So I feel that there are multiple factors which may be a high risk. So if your patient is male gender, above 45, above 55, has a size more than 4 centimeters and a rapid history, I would definitely consider this to be high risk. If the patient has a family history and a prior history of radiation, it is high risk. We know that almost 60% of your patients are non-medullary but familial thyroid cancers. So if there's a past family history of thyroid cancers, you need to take into consideration. This radiation therapy was a thing of the past where people used to be radiated for lymphomas or acne and all. Now very few people are actually radiated for any indication other than cancer. So this, or if the patient is close to areas which are having radioactivity, those patients are high risk, like the Chernobyl disaster. Those patients are very high risk. So if you get a thyroid cancer, you should go total thyroidectomy. So if you cannot pick one, but if you have a combination, you should consider this patient as a risk for malignancy, and when you do the surgery, you may consult the patient for a total thyroid.
Sir, one thing, sir. If
Please.
paraparably, if I got gross extrathyroidal extension, there is another factor for high risk. And paraparably, yes, introp or paraparably. And if I see there is a posterior or central compartment node which is suspicious and a frozen comes positive, there is also high risk. This keeps in mind also. Thank you, sir.
So the message is that high risk group. So these are risk group, low risk group. Low risk group, so size. The most important, the age, size, this and sex. These three we can get easily. Okay? If there is no family history, if there is no abnormal histopathology, then we will have to consider these three together, especially this size. If it is 4 centimeter or more than 4 centimeter, if he is a female, if she is 25 years, what will you do? If she is 25 years old, if she is female, the node is 5 centimeter, what will you do? You will do total. So what does it mean?
Size,
it is female.
single
You say
factor
it
also.
is female. It is age. Age is within this limit. But say
Size.
she is 14 years old, ladies. I am telling you. If size is 5 centimeter, if she is female, what will you do? 2 in the low risk criteria. 1 is the high
High
risk.
risk, yes, sir.
So I'll have to give more importance on this. The nodularity. So not only this is a nodule, histopathological nodule. So it will give the more importance to us usually. So Hassan Bhai has got correctly told age is important, but size apparently we give the more importance to the histological side. Okay, next. It is a very short board we are talking. I told you. So you can see this is the madam you told regarding this radioactive iodine. They showed the radioactive iodine given, not given, not given. Same result in case of low risk group, that is the T1, T2 group, low risk group. So this is the message for you people that radioactive iodine given or not given. It is March 10, 2022 in New England Journal of Medicine. They have published this paper, very recent, Prathamesh Bhai. They have shown it. So this is another message for the people that you people, madam, will you want to say anything?
Yes, I agree with this article. We are following after getting the information from ATA guidelines. We just prospectively keeping the macrocarcinoma patients in observation at my institute, and we have got 6% recurrence within 3 years. So in ATA guidelines, you can see in that there is 1 to 6% recurrence rate may happen in low risk group. So in some cases, we discuss with the patient that you have risk for recurrence 1 to 6% within 3 or 5 years without giving the radioiodine or giving the radioiodine. What you will choose?
When do you face,
Sometimes we discuss with the
when do you
patients.
face
for
problem when we advise total thyroidectomy followed by radioiodine? What do you feel?
No. In case of intermediate and high risk group, we blindly give the radioiodine therapy, as you referred to us. In case of low risk, still we discuss with the patients that you have some small percentage of recurrence without giving the radioiodine therapy.
Okay, thank you, madam.
Yes.
Next. Just
At
I
my
have to
institute.
finish it. Few more questions. Few. The confusion. If lymph nodes appear after radioactive iodine, before that, ultrasonograph guided FLC, is it always necessary for all nodules? Ultrasonograph guided FNAC, is it necessary for all sorts of nodules, say 2 centimeter, 3 centimeter, subcentric?
Actually, we nowadays we are following the thyroid criteria and the lymph node appearance on ultrasonography as we doing the ultrasonograph ourselves. So we like to do the FNAC from that particular lymph node. Sometimes the bigger nodule, a bigger lymph node does not have the malignant appearance. So it is good to do the
Okay, Sattar,
ultrasound-guided
say
FNAC.
single one lymph node in level 2, it is 2 centimeter, it is palpable. Then what should you do?
According to ATA guideline 15, if more than 1.5 centimeter, we have to do FNAC.
Ultrasound guided.
Ultrasound guided, preferably.
More than 1.5 centimeter, then you should go for ultrasound guided. Why? Pratash bhai.
So what Siddharth said is right, that if you should do ultrasound guided. He was talking about the criteria. On ultrasound, if you find that the nodule size is less than 2 centimeters and there are no high-risk features, no central peripheral vascularity, no microcalcification, no irregular margins, it is wider than taller. That means comet tail appearance. These are all low-risk features. So 2 centimeter low risk, you will still not do an FNA. If it is 1 centimeter and more, high-risk features, you will do FNAC. So look at the ultrasound, see the ultrasound characteristics, and then decide. So your ultrasonologist and you have to have a dialogue. When I send a patient to the ultrasonologist, I tell them, if you feel there is a high-risk feature, please do FNAC. So American guidelines, American radiology guidelines are there, we have stated that for you may have benign, you may have malignant, or that is high risk. If you have benign, if it is more than 2 centimeters, please do FNAC, even if it is benign. If it is less than 2 centimeters, do FNAC only if there are high risk features.
No, yes, you are right. But ultrasound guided, question of ultrasound guided. In our country, we cannot do all the FNAC ultra guided. Academically, you say all the should be, but there are some criteria. You see, that if it is cystic, if you see it is a subcentric, we have to do it. Almost we have no other options. But if it's a large one, it is a single one. If it is not cystic, it is solid, we have got another option without ultrasound. I am telling FNAC when we should do compulsory or we should do ultrasound guided. When we can do without ultrasound guided. I just want to know.
So
this.
I think today the time has come not to do your ultrasound or FNAC in your clinic. Please don't do it. So all of us can do, we were doing, but please don't do it. You need to do ultrasound. Like you said, if it's solid, cystic, there is solid cystic. So if you have a solid component within the cyst, I'm seeing a large swelling, I'll put a needle, I'll aspirate only the cyst. I'll say benign, I'll send the patient home. There's a solid component within it, which I need to target. So that cannot be done with you in your clinic. Get an ultrasonologist, see the solid area, he will target only solid area. We have moved ahead, we are now doing quality assurance. You do an FNAC, the report comes undiagnostic. It means your smear was inadequate. So you need a cytotechnologist with the radiologist who will do the smear, see the smear, is it adequate cellularity? If it's adequate cellularity, then go ahead and send it for diagnosis. Otherwise, don't send it. Do and repeat FNA. So ultrasound guided FNAC is mandatory.
So what is the message? The message is ultrasound guided FNAC is mandatory. But in our perspective, for the patients, for the availability, it is very, very difficult. Okay, next. There is another question. If lymph nodes appear after radioactive iodine, what should we do, madam? You have given the radioactive iodine. The patient was good. After 6 months, they have come with lymph nodes in the lateral neck.
Yes, we get this type of patients in 11% cases in our study group at my institute. And actually, we observe the lymph node size and their appearance on ultrasonography. And we discuss with our near-hand ENT surgeon and observe the TZ level as well. If TZ level is rising and jumping, and lymph node size, if it is sub-centimetric, we keep it on observation. If TZ level is below 10,
yeah,
and is it above 10 or subsequently rising, and size is rising, we send to you straightforward.
If it is
for redo surgery.
Madam, it is subcentric. If it is subcentric lymph nodes, say 1 or 2.
We keep them on observation for certain months, few months.
So if
to observe
thyroglobulin,
the size
yes
of the
madam,
lymph
if thyroglobulin level is not so high and it is not increasing gradually, if it is subcentric, the lymph nodes are not increasing, then you can wait.
Yeah.
You told like that?
Yes.
Okay, thank you. What is the role of markers, that is the BRFA, in DTC? COVID sir.
For practical purpose, the differentiated thyroid cancer, especially papillary carcinoma, we usually do not do markers.
Okay, up from the audience, anybody? Come on.
Actually, it is not a common practice in our country, but this is a recommendation that every papillary should have a BRAF, because when we are telling low risk group, there are some tiger in the cat. Some of the low risk may become high risk if it is BRAF mutant. So that is one part in the risk stratification. And on the advanced stage, when we give the treatment, when everything fails, if BRAF mutant, then we can use targeted therapy against BRAF. So there is two roles in early stage and the late stage. In early to risk stratification, the ideal low risk, if it is BRAF mutant, then it is no more BRAF, low risk, it becomes high risk. So this is the two thing. But unfortunately, it is very, it's not very available. Only few, 1-2 centers, private is very expensive. So we are not doing, but this is a recommendation as far as I know. Yes.
So this is mainly the prognostic you want to meet?
Yes, Prathamesh.
Come, Prathamesh.
We know what Professor Kamal said is being practiced now. We no longer are going to use all these soft markers to tell me high risk and low risk. I want to see the tumor. I want to know what is it. Is it a red mutation? Is it a BRAF? Is it the other mutation, PAX mutation? What is the mutation? Is it a mutated cancer or not? If it is a non-mutated cancer, you know that this is low risk. If it is a 5 centimeter, 10 centimeter, it is not going to recur. But if it is a 1 centimeter with a BRAF, with a TERT positive, this patient will be a high risk for local failure, for regional failure, for distant failure, and dying of cancer. So all high risk. So we know that today the time has come for us to do next generation sequencing for all your tumors. If you want to make the difference to the patient, and we know thyroid cancers are indolent cancers, but that 2%, 5% of cancers which will fail, will come back and keep troubling us, those are the ones that we want to catch. We want to do total thyroidectomy, we want to do prophylactic central compartment, we want to give radioiodine, we want to do everything for that patient now, so that the patient doesn't land up with a distant metastasis, doesn't land up with recurrent surgeries, maybe TKIs, maybe radiation. So what you can do for that very high risk patient is important. So we should ensure that we get the immunohistochemistry done. BRAF on its own may not really indicate a high risk patient, but BRAF, TERT mutations, these together today might indicate, and these are possible on immunohistochemistry. It's not that you have to do next generation sequencing. So costs are coming down. At a time when it was 1 and 2 lakhs for the next generation sequencing, now it's come to 25,000. So we know the costs are coming down. As more people do it, more centers come in, we can do these in a much more routine way, and the patients who deserve it should undergo more aggressive treatment.
Okay, so this is the time to think about this, and this is available in this country. Next, we are at just one slide more. Okay, we are trying to finishing. Thyroid cancer jealousy imaging has increased detection and treatment of low risk group. This is on journal. Just simple one thing. You see, in worldwide increase in incidence of thyroid cancer since the early 1980s, but with considerable variation between countries. In the USA, the incidence of thyroid cancer has increased from 3.6 cases per 100,000 population in 1973 to 11.6 cases per 100,000 in 2009. It is increasing. Small papillary thyroid cancers, the most indolent from the thyroid cancer, form of thyroid cancer, account for 90% of the cases. Conclusion: the incidence of small and indolent thyroid cancer is increasing, exposing patient to treatment inconsistent with the prognosis. We suggest a term that conveys the favorable prognosis for low-risk thyroid cancer, that is the micropapillary lesions of the indolent course of micropapillary cancer, and call for research to identify the appropriate care for these patients. So imaging and others, they are giving many incidental findings, and over treatment is going all over the world. So what we should need, you see, can you see this? In a race, stratification, okay? So in this disease, we should have stratification. Like social stratification, thyroid cancer also have the risk stratification. We need to do risk stratification to ensure rational treatment. Okay, thank you very much.